Okay, everybody, welcome. Thank you so much for coming and welcome to the Friday Huddle Extended Cut. So for those of you who were just at the Friday Huddle just a little bit ago, welcome back. Good to see you. And for those of you who are joining us right at 9, welcome. Thank you for coming. This is, for those of you who are not familiar, I'm going to introduce myself. I'm Jana Benton. I'm with the Oregon Center for Nursing. With me today is the whole Oregon Center for Nursing team. We have Dawn Schoenthal, Hannah Stanley, Rick Allgeier, and Priscilla Pimentel. And the reason why we are coming together is we really want to be talking about um, HR 1, the House Resolution 1, and how it's going to be impacting the Oregon's nursing workforce in particular. I think there's been a lot of news that has been coming out about Medicaid cuts and a lot of different things that are happening. And I think sometimes it's a little confusing about, okay, well, what does that mean for me exactly? And so I'm hoping that we can have a discussion today about what we know might be happening specifically for nurses and the nursing workforce in the state of Oregon and what we might be able to do about it. I'm also really pleased to have joining us today is Bob Duehmig, who is the director of the Oregon Office of Rural Health. So first of all, Bob, thank you so much for coming and really great to have you here. Um, he He's going to be specifically talking about some of the impacts that are going to be happening at a rural level in the state of Oregon, because that is one of the places that they've already identified is our rural areas and our rural facilities are going to be impacted pretty significantly. So I wanted Bob to come here and talk a little bit about that. The Just to get started, to let you know, the objective today is to really understand why Medicaid matters in Oregon and how the changes in the system could potentially impact nurses, particularly in the rural communities. I'm going to also start with this caveat that I am no expert on all of these things. I probably have about 60% of all of the knowledge that is needed to be able to share what information that we have here. But I do not have 100%. There's probably going to be some things in here that I say that might not be completely accurate, or there might need a little bit more context, or there might be something that I say in here that I might be missing something. All of that is valid. This is a very rapidly moving situation, and there's a lot of moving parts to it. So if there is anything that I say that you hear and you think, oh, wait, this isn't right, or there needs some correction here, please feel free to reach out to me, because I really would like to make sure that I'm going to tell you right now, I do not think that this is the last time we're going to have an extended cut about how federal policy changes are going to be impacting nurses specifically in the state of Oregon. And I would really love to be able to update you and make sure that you have as much information as I have. So if you have a question for this particular session, what we're going to ask is have everybody be muted. You can have your camera on or off, it's completely fine. But have everybody be muted for this. If you have a question, can you please put it over into the chat and we can address it as part of this conversation today. And then there'll be time for questions at the very end as well. So you know this. This feels, sometimes I like to just kind of start with something that everyone pretty much knows, just so that we have a really good, clear picture. But part of the reason why I like to do this is to make sure that we have all of the holes and all the foundation filled in as we start building in the discussion. We really need to understand when we're talking about Medicaid and Medicaid cuts that are happening at a federal level, and we're talking about how that's going to impact nurses specifically, it's really important to be able to look at where the money flows and how it flows from federal Medicaid funding all the way down to nurse jobs. So you kind of know this. There's money that starts at the federal level that goes into state budgets. The state budgets then allocate that to hospital or clinical revenue. That gets allocated into staffing budgets, and then that gets allocated into jobs for nurses. We know that cuts that have happened to Medicaid in the past have led to some staffing reductions, hiring freezes. There's been some increased patient loads for the people that are still working as nurses. Lower reimbursements means less ability to cover those salaries, especially in safety net and rural facilities. and the cuts will often hit community health and long-term care first, especially in rural areas. So let's just begin by talking about an overview of House Resolution 1 it's also known as the One Big Beautiful Bill. What I'm going to be talking about today is really going to be dealing with things that are happening as far as health policy that isn't necessarily related to education. There is a whole section that they're working on where they're going to be consolidating portions of the government like HRSA, the Health Resources and Services Administration, and the National Institutes of Nursing Research, and some things that are going to be happening with Title VII and Title VIII. We're not going to be talking about that specifically today because since Bob is here, I really want to be talking about the rural part of what's going to be happening. That's all going to be for a different extended cut where we talk about what that's going to be doing, especially to the nursing pipeline and what's going to be happening to get people into nursing school. There are many, many things that are going to be happening as part of this of House Resolution 1. Nobody has been able to give an exact number of how big this bill was. It was anywhere between 800 pages and 1,000 pages, depending on who you ask. But it's very big, and it really is geared at trying to reduce federal spending over the next decade in a lot of different areas. When we're talking about some of the healthcare impacts, these are kind of some of the bullet points of the things that we know is going to be happening. We know that there's going to be they're anticipating that the amount of money that's going to be the spending for Medicaid is going to be reduced by an estimated $715 billion to more than $900 billion over the next 10 years. In the state of Oregon, we know that, the experts have, or with the some sources have said that they expect that the state of Oregon will lose about $1 billion of revenue in the 2027 and 2029 biennium alone. So that reduction in Medicaid spending is going to impact nursing quite a bit in the state of Oregon. We're estimating that about 14% of the entire nursing workforce is working at a place that is primarily funded by Medicaid. So that the reduction spending is going to be pretty significant. There's going to be some new work requirements where they are asking adults between the ages of 19 and 64 need to be completing 80 hours a month worth of work or job training or volunteering to maintain coverage. That's going to be a new administrative burden. Shortened renewals instead of renewing annually, they're asking they will be requiring people to verify their eligibility every 6 months. My daughter, who is going into medical coding and billing, I was explaining this to her last night, and she was pretty angry about the administrative burden that people like her are going to be having to do because they're going to be doing the eligibility redetermination every 6 months. Well, they're also looking at Medicaid beneficiaries. Some of them will need to start paying copays of $35 per service. That might be, if you've got somebody that's just getting one checkup, $35 might not be a lot. But if you've got somebody who has a chronic illness and has to be going to get treatment on a regular basis, that could build. There's also going to be some limits on Medicaid reimbursement and state financing. The bill is going to limit states from being able to pay providers more than what Medicaid requires. At the same time, they're going to be decreasing any taxes that a state might um, be applying to medical providers, so that will make it harder both for the state to be able to attract providers, especially in rural areas, and also raise money from providers by adding additional taxes to them. And then finally, there will be elimination of coverage. There's going to be they're barring federal funding for gender affirming care, abortion related services, and certain immigrant coverage. So there's a lot of changes that are going to be happening here. One thing that I wanted to put together, and this is based on a summary that I looked at from the American Nurses Association, the Alliance of Safety Net Hospitals, and USA Facts, which I basically just borrowed the way they put their chart together. But this gives you an idea about how things are happening and when they are happening. The one thing that I thought is very interesting about how this bill is structured is that it starts in 2025, but a lot of those requirements, the work requirement, the insurance eligibility, the reduction of the provider taxes, they come later. And I wanted to kind of also put a note in there about when the elections are going to be taking place. Because when we get to the part about recommendations, a lot of the recommendations are you got to call your elected official. That's why, is because when these things are going to start taking place, they're going to be taking place in between when elections are going to be taking place. So this is kind of when to expect things to be happening. Okay. So Bob, this is where we're going to get into you because we're going to be talking about why why there is going to be a more significant impact on rural facilities as opposed to urban facilities. Um, I think that a lot of it we kind of already know. Rural facilities have a higher reliance on Medicaid, and cuts can lead to some service closures. We're already seeing that with some maternity wards, maternity units being closed in various parts of the state. Urban facilities have more of a private pay for for insured patients. So they've got a different payer mix. So they can, if there's a cut in the amount of money that they're getting from Medicaid, there might be more money that they could be getting from private pay. But it can shift resources away from underserved neighborhoods and long-term care facilities, even in urban areas. And all the work and eligibility requirements may push patients to the emergency room. There is a portion of the bill called the Rural Health Transformation Fund. Bob, I'm going to let Bob describe this because this slide is basically Bob's slide. I copied it verbatim from a policy update that Bob gave for the Office of Rural Health on July 25th. So, Bob, would you mind kind of explaining a little bit about the Rural Health Transformation Fund and what we know about that?
Yeah, absolutely. Before I do that, thanks, Jenna. I want to say one thing where I think there's a really important role for nurses because of where you sit in the whole
Yeah.
healthcare delivery system and with patients and sort of carry a lot of the credibility on your shoulders for our system. You know we have been talking about the negative impacts of HR1 since the start, since the president put out this reconciliation bill. And we stand by those problems that are going to happen because of this. But to the point that Jenna made, this was timed out so that it would not they hope, impact the next election cycle. So if this took effect like they had originally intended it to, cuts to Medicaid recipients, the impact to hospitals, clinics, and other delivery models would have been felt well before the elections itself. And they know that is not going to be positive to them. So the worst of the impacts of of HR1 will come after the next election cycle. So the conversations we have now, understanding what the timeline is really important for us to be able to continue to talk to people in our communities about what is coming. Because if we don't, nobody is going to be prepared for it. People inside the facilities won't be prepared for it. Our patients won't be prepared for it, and our communities won't. So I do think that the more you all can learn as this goes in, and we move toward the implementation of these changes, that the better, because you all will be the ones that are right there, hearing it from the patients, but also feeling it from the cuts and the other impacts to the rural facilities. So the HR1 cuts over a 10-year period $155 billion out of the Medicaid program from the federal level. So that is a huge impact. And again, the bulk of that 155 million is going to come in the second 5 years. So that will be after the next presidential election as well. So, but we will begin to feel these things beginning next year. We also talk about Medicaid cuts, and it should be noted that there was a 2020 bill, 2020 um, 2010 piece of legislation called the Pay as You Go bill.
Mhm.
And this was when they were all once again concerned about the deficits, because you notice that deficits are only a concern when you're not in power. Once you're in power, it's okay to run up the deficits as much as you want.
Mhm.
And so, within the context of that bill, it requires Congress to cut funding across the board in order to cover the cost of uh, of debt paying programs. So we HR1 adds 3.5 trillion or 4 trillion, I think was the last number that the CBO came up with. So $4 trillion to the debt. So under that 2010 legislation, there's a thing called sequestration, and it requires the suppression basically of everybody else's budgets and cuts to make up for that amount of money. The one thing that's not been talked about is unless Congress steps in, there will be on average a 4% cut every year going forward on Medicare. Now, the chances are in an election year, they will go back and exempt Medicare from that, but it will still impact other programs. But it could, if they choose not to do anything about it, have beginning in 2026 a 4% cut to Medicare. And then that, of course, will just build. So that will also have a big impact on our rural facilities. I put several maps in the chat for people to look at. One is just the levels of Medicare and Medicaid by county. One is the level of births paid for by OHP. So to Jana's statement earlier about labor and delivery, already under pressure in our rural communities, this is only going to get worse. When you look at those percentages and understand how many people could be losing their coverage. The third one that I put in there, I believe, let's see, yeah, poverty. So people can understand what the poverty levels already are in our rural counties and what that's going to look like when people don't have health insurance and how that can impact as well. And then the last map is Hispanic populations by county. And that's extremely important because as we all know, it's kind of a dangerous place to be in America as being Hispanic, depending on where you are. And so we have communities. I was at a clinic down in Woodburn a few weeks ago where there had been an ICE rumor, and there was absolutely nobody in the clinic. They said all their appointments got canceled that day. So thinking about the impact on care delivery by county when it comes to the population, the Hispanic population. So those are kind of important to keep in mind as well. So back to this rural fund. You'll often hear me calling it the Rural Slush Fund. So one of the things that Congress did, knowing that they were cutting 155 billion, knowing the huge impact this was going to have on rural communities, red counties, which voted for them,
Mhm.
they came up, and it was a big idea of Susan Collins out of Maine to put $50 billion to aside to help in a transformation fund for rural. Now, the biggest thing to keep in mind about this money, we're losing $155 billion in revenue over here over 10 years. This $50 billion cannot be used to substitute federal payments for Medicaid. So it cannot be used to offset the costs of the cuts to HR1. So this money could be invested in hospitals, clinics, communities to improve. And at the same time, those facilities could close because of lack of revenue. So there's a real big disconnect between what's happening in HR1 and what this money is actually supposed to be used for. So it's $50 billion over 5 years. Out of that 50 billion, it's split into two. One half of it, 25 billion, will be awarded to states equally. And the other 50% is basically up to the CMS director. Now, there's some formulas in there about the number of rural facilities, et cetera, but it is really designed so that the CMS director is going to be able to direct those money to states that he thinks probably deserve it. And I'm not going to say exactly who those states are going to be, but I'm pretty sure people are clear which states will be getting that extra 25 billion and which won't. And I'm telling people do not expect Oregon to get any of that second 25 billion. Focus on the first 25 billion that we have a potential access to. So these are one-time funds. If all 50 states are approved, it could equal about $100 million a year for 5 years. There is an application that is due December 31st, 2025. And the way it's worded now in the legislation is the application is due and the awards must be made by December 31st. So we are operating here a little bit on the blind. The feds want this in and they want the awards made by December 31st. We don't know what they want yet. So there's been no no guidance or anything given from CMS on what to expect. What we do know is that the CMS director, Dr. Oz, has said that the application should come out in the early part of September. So we're hearing everywhere from the last week of August to the second week of September. So somewhere in there, we will get that. We'll have about 4 to 6 weeks to write the application, and then they'll have 4 to 6 weeks to actually score it and make awards. So that's really the bulk of what we know at this point in the game. The lead for every state, the way the legislation is written, is for the governor to make determinations of how the state's going to do that application. And different states are moving at different speeds. And I remind folks that this is one fund, this is one piece of a lot of things HR 1 is doing to states and state budgets. So we have massive cuts to education, massive cuts to healthcare. We have all of the cutbacks coming on FEMA and everything else that's going on from the federal government right now. So we're trying to make sure everybody understands that we are very stressed about lack of information at the moment, but are also understanding the state is balancing multiple things. So we're trying to, keep that in balance as we go. Here's what the Office of Rural Health has been doing since we have been able to figure out more and more what's going on. We are meeting with individuals who have an interest in this fund. So hospitals, clinics, federal qualified health centers, EMS, rural health clinics. I'm going to ask you all as we go through this for your feedback on this and things that you think are important. Because we need to get a conversation going. So when the governor makes a decision in the coming days about how we're going to move forward on this, we are at least somewhat starting those conversations to pull the application together. So there's a few things on the application that we do know, and I'm going to put some of this in the chat. It's a little bit, it's going to be a lot of words. And just the way it goes in there. So I apologize for that. Here's some of the things that we do know about the fund. Oh, it's telling me it's too big. So let me do this.
While he's doing that, I just, wanted to let you know that when 2 weeks ago, when Bob presented this slide, there is a line on here that says, we don't have the application yet. And I didn't include that because I was really hoping that Bob would say, oh no, the application came in the last 2 weeks. But unfortunately, I could have left that line on the
Yeah.
slide because we still don't have the application.
Yeah, we still don't, sadly. And so what they require us to do in this application, though, is to put together what's called a rural health transformation plan. And then in that plan, we have to include three of the things that are listed here. One of these three, we can do more. What these conversations that we're having now are trying to have are to get people's feedback on what they think are priorities within these areas. So as you can see, it's within that. Let me pull my other sheet up here so I can read a little bit better. So improve access to hospitals, other health care providers and care items, health outcomes for rural residents. There's some workforce pieces in there. There's some technology pieces in there, et cetera, right? So it's very broad. And that's a good thing. So they're going to write the guidance around this broad legislation, and they will begin to tighten that up and give us a little bit more clarity about what we can and can't do um, uh, from this legislation as it's written. It's the same as in the state when the state legislature passes a law, and then it's up to an agency to implement the rules. It's kind of the way it works with the grant making pieces on this. So we're looking through in different ways that we can take these activities, the direction that they give us here, and make a broad enough application. Again, it'll come a little bit more narrow as the guidance comes out, and we have a better understanding of what they say we can and can't do. Here are some things about how kind of a next level down to how they say funds can be used. So I'll put
Bob, would
that.
it be easier if I just let you share your screen?
Um, yeah, you know what I can do to Janet, when this is done,
Hmm.
when we're done, I will send you this document I have.
Okay.
You can get it out to folks if that's
Yep.
easier.
Yeah, let's do
And then
that.
everybody has it in front of them.
Yeah.
So you'll see you'll see in these activities that there's some great things. Um, if we were writing a grant that we could do carryover funds with, and we had a little bit more people to, some project officers to work with and in a larger programmatic format, this would be great. But everything that we do has to be basically done in 5 years because we're not going to get the money beyond 5 years. And we only have a limited time into the second year to spend the money. So money awarded to us in 2026 must be spent by the end of the fiscal year in 2027.
Hmm.
So you've got a limited time to spend a lot of money to get the outcomes you want. And at the end of that period, if you don't spend that money, they will take it back. It's not like we can ask for a carryover in
Yeah.
this. So it's a little bit confusing. I'm sorry it's that confusing as we kind of talk about it, but that's the reality of where we are today. And so what we're looking for from folks on this is if you have ideas reading this through, and again, Jana will get it out to everybody today,
Hmm.
and you're like, here are some things that I see from a workforce perspective, from where I work in my hospital or clinic or long-term care facility or wherever you're at in a rural community. These are some things I think could work, that could be a systems change with some investment upfront that we could show some outcomes within 5 years. We're also asking for people to think about sustainability because we don't want to put a lot of money into something and say, look, it's working for 5 years and boom, on year six, it's got to die because we don't have funding for it.
Yeah.
And the thing to keep in mind as we do this as well, there's a lot of things going on with HR1 on the cuts to Medicaid, right? And I mentioned also the issue of potential Medicare, but we are going to be dinged on our provider tax. So that is going to start to be pulled back. And that is a way we pay for a lot of activities within the Medicaid program. We support a number of or of immigrants without legal status in Oregon through our own general fund dollars. All of these things are going to be impacted because our revenue is about to go in the toilet. And there's several reasons for that. One, just the federal cutbacks on things sort of across the board. The Department of Education is being hit really hard with the amount of money that comes through there and through grants because of their attempt to get rid of the Department of Education. So
Hmm.
that falls back on the state of Oregon. We have an unfortunate position of being where our income tax, well, we have a lot of tax problems. One is the people of Oregon have always decided in their infinite wisdom that we shouldn't have a consumption tax. Therefore, when we hit bad economic times and people begin to lose their jobs and salaries go down, it hits us hard because that's our main source of revenue. And it takes us a long time to get out of our budget holes because we have no consumption tax to help fill that up faster. So as we go into this hole over the next year or two, know it's going to last a while before we can pull ourselves back out. We're also we are also attached to the federal system, right? So we're connected. When changes happen at the federal level, those parallel in our own tax system when it comes to income taxes. So as federal taxes go down and some of the changes that have been made in the tax laws, that means our revenue within our own income taxes are going to go down in Oregon and create a big hole. We could vote to disconnect from the federal system. We've done it before, but we've never done it permanently. To
Mhm.
make it impactful, we would have to do it most likely in this next special session at the really at the latest, but I guess they could do it in the next short session in January. But that's a huge hole that's going to really hit us hard.
Yeah.
Intel is laying off. Providence is laying off. So as we have the impact, and a lot of the Providence pieces are already starting for a number of just larger structural healthcare pieces, but to prepare for the impact of HR1, we're going to start to see layoffs and structural changes there. Intel has had their own internal strife, but as the tariffs and the other pieces come in, that's going to have a huge impact on the economy. And Oregon has a fairly, import-export impacted economy. So the tariffs are going to hit our revenues hard. And all of that is going to make the bucket that we can spend even smaller. So when these cuts come to Medicaid and we're like, oh, well, the state can pick that up. No, the state can't.
Mhm.
So we're going to start to see these cuts across the board, healthcare, education. They're doing some things on transportation in the special session, but it's not what they thought they were going to get. We have FEMA issues, and so it's just an array of stuff. So our finances are going to be bad. I was just in a meeting with Representative Noce last night, and that's
Mhm.
one of the things that they're trying to caution people on is we cannot backfill like we think we might be able to. And so I put that out there to say that the sustainability of these dollars is going to be important. Expecting the state to come in and be that sustainable source is not going to
Mhm.
happen. And know that as we implement these HR1 impacts, they're not standalone. So the schools in your rural communities are going to be suffering. Economic development is going to be so.
Mhm.
So I'm going to leave it there and ask if folks have questions because I've rambled on. I sometimes feel like I put all this information out there and it doesn't offer as much clarity. It just offers more confusion and stress.
Well,
Certainly
yeah,
not my intent.
there was a question earlier about from Karen. She asked, do rural health centers get money from the U.S. Department of Agriculture, and has that been cut? Or have rural hospitals built with federal funding had their cut? Or do government agencies like the Health and Human Services Rural Development Agency support these facilities?
Yeah, some great questions. So let me clarify about a rural health center. So there are rural federally qualified health centers, and then there are certified rural health clinics, and there are two different types of organizations. So a federally qualified health center which are in both urban and in some rural areas, are entities that have a defined service area. They have boards that have to, they're all nonprofits. They have to have a board of 51%, I believe, consumers, or at least 51%. They have some requirements in which they have to offer services. They get an annual federal payment to federal each of the federally qualified health centers to help support them. Their providers have limitations on liability, impacts, and a few things like that. So they have some support that comes through that process. At this time, those have not been cut greatly, as far as my understanding, that support is still coming in. But they are almost, I think most of them are at least 80% Medicaid, right? So the folks that go to federal qualified health centers are are Medicaid recipients for the most part. And so that means the revenue of our federally qualified health centers are going to suffer. And do know that in context of all of these, the workforce piece is going to impact all of them. So that's going to make an impact. And know that, what I didn't have and don't have a map of is dual eligibles. So we have a lot of seniors that are still receiving Medicaid as well. And that includes in long-term care. That's a huge impact on certified rural health clinics. They can be for-profit or nonprofit. Although you can pretty much check with any certified rural health clinic that's for-profit, there's not much there. That has mostly to do with governance structure. And a rural health clinic can be owned by a hospital or it can be independent. And so there's a mix we have 90, I believe we're at 98 rural health clinics at the moment, and they are about 50-50 between independent and hospital-based rural health clinics. They don't get direct funding. Unlike an FQHC that will get some direct funding, a rural health clinic does not get direct funding. They do get enhanced reimbursement as long as they meet the requirements and go through the certification process for Medicaid. But likewise, in a rural community where the rural health clinics are, they're very heavily dependent on Medicaid and Medicare, so their revenue costs are going to come down. Department of Education does not directly support healthcare programs in either of those or in our rural hospitals. They do support and they do have some programs through the Rural Development Agency, loans and I don't have any grants at the moment, but various programs that can help a facility meet some of their capital needs, depending on what those are, and sometimes with things like EHR. But most of that's done through loans, and it's not as easy to access, particularly for the clinics, although some hospitals have used those supports in the past. The Department of Education is the one that operates SNAP, however. And so that budget took a huge hit in HR1. And so you're going to see the levels of food insecurity increase greatly across the board, but in urban and in rural as well. So that's a big piece of the agriculture.
Mm-hmm.
And then as far as HHS goes, so HHS doesn't do direct pay per se to any facilities, although I say that, but the Federal Qualified Health System, those go through HRSA and through HHS. So there are some. One of the unknowns for HHS right now is what their restructuring is going to look like. So
Right.
Secretary Kennedy is all about making America healthy again, and in doing so, wants to restructure how the agency is put together. So we don't know entirely what that's going to look like. The courts put a stop to that for a while, and then the courts now say he can do it. We're all waiting with bated breath as to what we think that's going to look like, where agencies within HHS are going to move around and how programs are going to move around. So a lot of the money that we get, in fact, the majority of the money that we get through the federal government comes through the Federal Office of Rural Health Policy, a division of HRSA and HHS. HRSA is going to go away as an agency or an agency within HHS, but we don't know what's going to happen to all of its parts and whether they're going to be kept together and moved to one location or another, or if they're all going to be ripped apart and done in just very weird and odd ways. And do know that the NIH, CDC, all of that is under HHS, and that restructuring could impact them in a great deal as well. So there are agencies that are getting cut. The president's budget came out what he considered his most full budget in March.
Mm-hmm.
And it was still a skinny budget. So they had dollar amounts up there that didn't really tell us a lot, and it didn't really go into explaining what was going to be, what programs would or would not be funded. But the HHS budget was $94.7 billion, and that was a cut of $31.3 billion from 2025. So that means there's going to be, if they were to go forward with that budget, there will be a lot of cuts coming down and through HHS. But because the president's budget has not been detailed, we don't know what their proposals are. Now, just a quick side on the appropriations process. The president puts out his budget. Congress then does their own budget. Uh, Normally, we work very closely with the House and Senate. We have a lot of allies there that if the president cuts a program, we can get them put back in and people feel a little bit more confident what's going on. This year, we don't really feel confident about anything Congress is telling us because they will sit out and complain, oh, this is bad, and then they turn around and fold and do everything he wants them to do anyway. So what we do know is last week, the Senate Appropriations Committee took up the Labor Education HHS budget. And in that, they restored programming for our office and most of the rural programs that the president cut in his budget. That's the first of the many steps that need to be taken. And traditionally, the labor HHS budget starts on the House side, not on the Senate side. But as you all know, the House went home because they didn't want to take some sensitive votes. So they went home early, and they won't be back until the first week of September. We don't know what their labor HHS budget looks like. So it could look just like what the president has, or it could be a little closer to what the Senate does. But either way, when they pass theirs out, then they're going to have to negotiate to see what the final piece is. One thing that many of us think might happen this time around is we won't get a budget at all. For the last 25, 30 years, normally the budget process should be that the committees of jurisdiction hear the budget proposals, they pass individual budget bills, the president signs them. October 1st, they start. The last 25, 30 years, they haven't been able to do that. So at the end of the year, when we're getting close to the start of the new fiscal year, they pass these massive omnibus bills that just covers everything. And I will say the Republicans are very correct in saying that those are boondoggle spending bills. And there's so much money that they spend that nobody's had any oversight on because they don't do any hearings on it. They just clump it all together. This year, the House Republicans in particular, there's a group of hardcore conservative fiscal conservatives who, by the way, have folded on every other principle they have on fiscal responsibility. So we can't be assured they're going to stick to this one any more than they have their others. But they have said they will not do an omnibus spending bill because it is too expensive. They have started talking about a continuing resolution. So when the budget expires on September 30th, Congress can pass a continuing resolution for a period of time. And that just means the government will be funded at its current levels through a defined period. Often happens at the end of a fiscal year to get us through a few days to a month or so. If they don't pass a continuing resolution without a budget on the 30th, then come October 1st, the government shuts down. And we've seen that happen before. In his first term, Trump was able to get the record for the longest government shutdown on record. We are going into an election year. So there's a lot of things in play going into this budget conversation that we're having. So Congress doesn't come back till the first week of September. They do not have time to complete their budget hearings and processes and get the budget passed without either doing an omnibus bill or a continuing resolution. So we believe at this point in the game to prevent a government shutdown, which I think both sides want to avoid, and to keep from fighting over important programs that would look bad if they were cut during an election year, we will most likely get a full year continuing resolution, which just means come September 30th, they'll pass a budget bill that says we are staying at the exact same funding rate as we are today. So it just funds us on 26 through the same budget numbers we're using today. Keep in mind that the budget numbers that we are using today are based on a continuing resolution that was passed on March 5th of 2025 based on 2024 budget numbers. So if we go into fiscal year 2026 on a continuing resolution, we will be operating on fiscal year 2024 funding levels. So the conservatives that don't want to do an omnibus bill can say we're saving a lot of money because we haven't increased the budget in 2 years. Now, that's only partly true because within the reconciliation bill, they moved a lot of money and agreed to spend a lot of money and gave a lot of tax credits. So it's not necessarily a fair statement, but when it comes to direct budgeting dollars, they can say that. Many of us are at the point now, and this is how the whole thing changes and where we start out, right? We can now say, by operating at 2024 levels in 2026, we've won. We should be excited because our programs aren't being cut and are in fact funding them. So it shows you that this whole conversation is just flipped on its head on where we are today. But
And it
that's
could,
what we
yeah.
sort of see is happening with the appropriations. So to your question, Karen, on the other appropriations and how that's working, that's where those cuts are and where it might be a problem.
Very good. Thanks, Bob. There's some other things that are in the chat of some ideas that we could be doing differently. But for the sake of time, thank you for all of that. And for the sake of time, I want to go back to the presentation because to get back to what can you do or what can nurses do under these circumstances. So we've learned a lot about the impacts that are going to be happening from a rural perspective and how that's going to be impacting so much of our state. From the nursing perspective, these are 4 areas that I anticipate we're going to be seeing some impacts. There's going to be job security, just like Bob was talking about. Those tax revenue cuts and those payment caps, they're going to lead to hiring freezes and some layoffs, particularly in our rural areas, which is going to be really difficult for people to be able to get access to care. There's also going to be some staffing pressure. We do have their safe staffing law, which is House Bill 2697. That has some requirements about what staffing needs to look like. And if we're going to be having not enough revenue, especially in our rural facilities, and yet we have the law that's required that has some requirements for safe staffing, that's going to cause a lot of operational strain. And that's also, again, going to be pushing more patients into the emergency room because they're not able to get care outside of the emergency room, especially if they have to do constant re-eligibility checks and work requirements. So that's going to even further impact patient access, which, based on the research that OCN's been doing over the last 5 years, we can see an increase in the burnout and retention problems that are going to be happening with nursing, just because of the amount of administrative work that's going to need to be done by nurses to be able to navigate all of these changes. Then we're going to have higher patient volume, more operational strain, and that's going to create more burnout for nurses. So kind of what I think is next, and what I think that, and Bob was getting to this, and this is kind of where we are right now. Here are things that you can do. The main thing, if I can just, I want to make sure that we've got at least leave the last 10 minutes for other questions. And I saw Rachel Prusak had her hand up. Oh, she changed her mind. That's completely fine. I want to make sure that we have some discussion. If there's anybody who has any questions or would like anything else, this is kind of the most important thing. Right now, it's the stories that are happening to you as a nurse in your community that our legislators need to hear about. There are going to be 2 elections, major elections that are going to be happening before some of the more painful parts of this reconciliation bill are enacted. And there needs to be stories about how that's actually happening, how that is impacting you and your communities right now. We talk about this in our Friday huddle during over and over again, where nurses are consistently considered the most trusted profession in the United States. So what that means is that people are coming to you as nurses and they're asking you questions about, what is this weird rash that I have on the back of my leg? Yeah, they're asking you that question, but they're also asking you questions that are related to healthcare. So really, as nurses, it's important to stay informed and understand how this is happening. There are so many spinning plates right now, more than I think the last time I saw this many spinning plates was when the pandemic first started. There are a lot of spinning plates, and Bob and myself, and there's a whole lot of people that are trying to track each and every one as best we can. As if you have questions, definitely reach out to us. We will try to continue to do more information sessions about this topic so that you can keep informed. But also contact your representatives. Representative Nost just had a town hall that some people were able to attend to hear what's happening there. Senator Merkley and Senator Wyden have been at the forefront of trying to do what they can to reduce the impact, the financial impact that these cuts are going to have on the state of Oregon and all states across the country. They need to hear your stories. They need to hear what nurses are going through. So that's pretty much where we are of what we can do. So here's the key takeaways. I'm going to make sure that this is all shared. It's a critical source of funding. These caps are going to really affect people, especially in rural facilities. And those real world stories are what we need to be able to influence those policy decisions. Here are the sources that I am currently looking at. These are the places that I'm looking at. And if there are more places that we need to be looking at and more places to be able to track the spinning plates, please let me know. I will compile a list of all of the different things. These first three are the national ones that are related to nurses. The American Nurses Association just did a summary of the One Big Beautiful Bill Act that just came out last week. Here is a link to that. The National Rural Health Association has some great advocacy, and the Congressional Budget Office lists the facts that are related to how the budget is going to be impacting the states. But the Oregon Health Authority and the Department of Human Services in Oregon both have dashboards that are really written to the patient perspective to try to help the patient understand what these cuts are going to be doing for them. And then, of course, the Oregon Office of Rural Health Policy updates. That's a call that they have. Are you having that once a month, Bob?
Yeah, we're doing it monthly now.
Okay, great. So those, if you would like to register, I put the link in the chat. Or here's the link right here. That's going to be included. You're welcome to include that. And if you have other resources that you're looking at, please put them in the chat. Actually, yeah, thank you. Bob also put in the chat a link to find your legislator. And we shared all of these links in the chat too, so that if you are here and you want to be able to do that, the link for the policy updates are not working. We'll double check on the policy updates for the Office of Rural Health and make sure that this one is correct. I might have put that in incorrectly. So the last part, here are the questions. What else should we be paying attention to that we are not paying attention to? I kind of started this up to say, I think I know about 60% of everything that we need to be paying attention to. I think Christiane put earlier in the chat, like, what's going to be happening with nursing schools? Yeah, I think I need to do an entire extended cut specifically on nursing schools. I really do. Based on, I was gonna, I yesterday when I was looking through my outline for this, I was trying to see if there was a section for it, and I didn't think I'd be able to get through it in an hour. So I didn't really talk about nursing schools, but I want to do a whole extended cut just about what's going to happen with the pipeline, with the area health education centers, all of that. So there might be another extended cut for that. But what other plates should we be watching? What other balls that are in the air that we should be paying attention to? Go ahead, Rachel.
So I don't have anything else to add for what to pay attention to, but I love the idea of the education nurse education cut. But I just wanted to comment on Bob, when you presented and said, I just said a whole lot of things and I probably overwhelmed or stressed people out. I think it's really important that you keep doing this. And Jana, it's brilliant for you to say Oregon Center of Nursing is about workforce. It's about nursing workforce and having an invited guest like Bob who can speak to us on this stuff. So this partnership is exactly what Oregon Center of Nursing and Rural Health should be doing. So thank you. Because yeah, it is scary and yeah, it's overwhelming and yeah, it is stressful, but we have to start thinking about what are we going to do? And then from the Oregon State Board of Nursing perspective, since it was brought up in the chat, one thing I want to share with this group so you can share out. One of the updates to Division 31 was I spent some time working with the director, a retired nurse of the Oregon Free Clinics. And since we know there's going to be a lot more of that and needing a lot more of those nurse emeritus, I think you should let people know in your community who are transitioning into potential retirement about that because we removed um, clinic hours, we removed practice hours, and things are all about CEs now and a very small amount of CEs. And that's important to keep up the nurse emeritus, the lot of people who stay and volunteer at the free and charitable clinics. So that's the one connection from the Board of Nursing. And then lastly, Bob, is there any, are you seeing that these applications are going to be similar to the kind of ARPA funds that everybody was fighting for? Or have you not got a glimpse at all of what they're going to look like? But just that like idea of how everybody's going to be fighting for money. And so those partnerships, almost like what nonprofits are doing now, so they're not fighting for the same amount of money, are happening.
Yeah, good question. I don't know that piece at this point in the game, and because there's just so much unknown and how they're going to come through. One of the things that we are really trying to do in the conversations that we're having now is to get people to think how to collaborate. There's only so much money, there's only so much time to do it. If we don't do it together, we are we're going to be in a world of hurt because we'll lose the money. And being a blue state makes it a little bit tougher. So we have to really watch our P's and Q's as we go through there on that piece. So we're hoping everybody will come together with projects and ideas that are sustainable and interconnected so that we're getting the biggest bang for our buck.
Yeah.
Yeah, and then the only other thing is what's interesting when you say it's a blue state for everyone to know, what that means is we've been the most kind of aggressive on ensuring access to Medicaid, whether it's the provider tax or which is a bipartisan effort, or whether it's a basic health plan to not have the churn, or whether it's the providing it for immigrants. So all these things are going to be gone and then back to the simple form because of that. So it's unfortunate.
Yeah.
Thanks.
Thanks, Rachel. And in the chat, Christian asked Bob, he's concerned about the state legislature will cut the SHOE program to save some funding. Are you,
Yeah, I was just typing back to that to his
oh,
point. The legislature gave $26 million in the budget this last time to support the provider incentives. So that includes SHOI. So everything is staying just around the same level as it was the previous biennium. So we're very
okay.
pleased with that. But 27, 29 is the year we're going to have to worry about because, as I mentioned, even if the economy starts to get better at the end of 26 or early 27, it takes us a longer period to get out, and so our budgets are damaged for a longer period of time.
Okay. All right. Thank you so much. Thank you, Bob, for everything. And thank you for everyone who participated. We've got about 2 minutes left. The one thing that I want to leave everybody with is I noticed that in the chat there was some discussion about what we could be doing instead. And honestly, if I know anything about nursing and the nursing community, you guys can come up with what we could be doing instead. You can come up with how we can make sure free clinics are taken care of. Just this understanding and just really understanding that the systems as they have been built up to this point are not necessarily going to be the systems that we're going to be moving forward with. And that's okay. It's uncertain, it's stressful, but it is okay because I really do believe that the nursing community and the whole state of Oregon can collaborate and can come together to make sure that everyone is taken care of and their healthcare is covered. So, with that, if you are, Bob put in the chat, legislators and policymakers are always looking for solutions. In fact, they are hungry for them. If you have ideas right now, they want to hear them. There's a lot of, throwing spaghetti at the wall and seeing what sticks. There's going to be a little bit of that while we're trying to figure out this uncertainty. But the one thing that I want to make sure that is certain is there are people like Bob Duehmig, and there are organizations like the Oregon Center for Nursing, and we are going to be trying to like unravel this knot as much as we can for you. If you have any other questions, please feel free to reach out to me at the Oregon Center for Nursing. If I had Bob's email up here before, Bob, you can put your email in here really quick. go ahead and send questions to Bob. But we're going to continue having these extended cuts and trying to go deep on some of these issues so we can support you through all of the changes that are happening. And with that, and there's my email address too. With that, thank you so much for coming. Thanks for this. Have a wonderful rest of your Friday. And Bob, thanks again for doing this. I really appreciate
Yeah,
it.
thanks for having me, Jana. Nice to chat with everybody.
Yeah.
Bye.
All right. Thanks, everybody. Take care.